Relaxed.
All right, should we get started?
Right.
Welcome everyone to the VCU Department of Internal Medicine Grand Rounds. Today is May 16, 2024. Today is one of our special lecture series that we have every year. This is the annual Blackard lecture sponsored by the Division of Endocrinology. So to get us started here, I'm just going to get us started here, but we have a few folks to give some introductory remarks before we get to the introduction for Dr. Auchus. So let me start with introducing Dr. Downs, and then Dr. Syme, our chair, is going to give a few remarks, and then Dr. Auchus will start his lecture. Dr. Robert Downs here is a friend of Dr. Blackard. He is currently retired with an appointment of Professor Emeritus in the Department of Internal Medicine and Endocrine Faculty, retired in 2013, I believe. His career has spanned over 40 years, focusing on osteoporosis diagnosis, prevention, education, and treatment, including clinical trials of new drugs for the management of osteoporosis and prevention of fracture. More recently, he has now for almost 10 years served on the Commonwealth Health Research Board, now as the chair appointed by the governor of the Commonwealth. So Dr. Downs is going to give some introductory remarks about Dr. Blackard, since he knew him personally, and introduce our speaker. Dr. Downs, if you want to come up.
Coming after me?
Yep. Okay.
It's a pleasure to be here today to introduce the speaker for today's William G. Blackard lecture. Bill Blackard joined the faculty here before many of you were born back in 1975 as chair of the Division of Endocrinology and Metabolism and director of the Clinical Research Center. I first met Bill when I visited Richmond prior to joining the faculty, which was in 1983. I stayed in the old John Marshall Hotel. Bill met me there for breakfast, and then we walked through the Capitol grounds where the azaleas were in full bloom, and into the Broad Street entrance to West Hospital, which has an interesting history itself, up to the 4th floor where his closet-sized office was in the Clinical Research Center at that time. The Clinical Research Center ultimately moved to the main hospital, to the North Hospital, after the main hospital was occupied a few years after I came here. Bill was a fabulous person. He nurtured a division that was collegial and friendly, and that was one of the things that attracted me to come here. He and his wife Telia welcomed us with open arms and treated us as family when we came. He had a wide range of interests, and I really remember most the excitement that he had when he had made a discovery or a new finding that challenged conventional wisdom. He stimulated the faculty here, and his wide range of interests really began when he was a resident at Duke. He published a case report of a patient who had familial hypophosphatemia, and the group at Duke after that went on to become national experts in X-linked hypophosphatemia and the treatment of hypophosphatemia. So I think he had a little role in that. His principal research interests and clinical interests were in the area of glucose metabolism, insulin secretion, and insulin resistance. And he, like today's speaker, was involved in research across the breadth of endocrinology. He loved being involved in all aspects of endocrinology. He was a friendly and engaging colleague, a great educator, an effective administrator, and he was a great friend. Many of you know John Nestler, who was one of his trainees and who ultimately became the chair of the Division of Endocrinology and the chair of the Department of Internal Medicine here. Bill had an untimely death in 1996 at the age of 62. I'm doing the introduction today because I'm one of the few remaining people on the faculty here who knew Bill personally. Our numbers become smaller every year. The reason for this lectureship is to honor and to keep alive the memory of Bill Blackard and of others who contributed to the excellence of this university. It's a pleasure today to be here for this. The Blackard lecture today is Dr. Richard Auchus. Dr. Auchus is the James Shayman and Andrea Kevrick Professor of Translational Medicine in the Departments of Pharmacology and Internal Medicine at the University of Michigan. And he also serves as chief of the Division of Endocrinology at the VA hospital there. He's the author of more than 350 journal articles, many book chapters, and he's lectured in national and international forums. He's been elected to the Association of American Physicians, was chosen to deliver the prestigious Lawson Wilkins Lecture at Pediatric Endocrine Society in 2022. And he's received awards from the American Association of Clinical Endocrinology and the Outstanding Clinical Investigator Award from the Endocrine Society. Like Dr. Blackard, Dr. Auchus and his group are active in a wide range of research projects, including basic biochemical principles and structural biology of steroid biosynthetic enzymes, comprehensive steroid analysis, and clinical trials and translational investigation in disorders of the pituitary, adrenal, ovaries, and testes that are related to hypertension, infertility, and obesity. Yesterday, the endocrine division heard an engaging presentation on new developments in the management of patients with congenital adrenal hyperplasia. And I'm delighted that Dr. Auchus is with us today to talk on the practical approach to the occult epidemic of aldosterone-mediated hypertension. I'm going to ask Dr. Simon to come to make a few remarks, and then I hope we'll welcome Dr. Auchus with open arms.
Well, thank you very much. I just wanted to personally thank you for taking the time to honor Dr. Blackard and to share your expertise. I had the privilege of sitting down yesterday with Dr. Auchus, and you can tell this is a physician scientist who loves what he does, and he still does it with lots of energy. And I'm just incredibly impressed that you brought so many discoveries to clinical interventions. And I think we'll hear about some of those today. And I'm sure Dr. Blackard, who I obviously didn't have the pleasure of knowing, would be very proud to know that you're giving this lecture today. And you'd be equally proud to know that you're coming and still contributing in lots of ways as an emeritus professor, Dr. Downs. So thank you very much both. And I'm just excited to hear what you're going to share.
Well, thank you all for that very kind introduction. I'm very honored to be asked to give this lecture today. I believe I met Dr. Blackard once or twice when I was a young endocrinologist. And I think the people who started the clinical research units around the country, like Dr. Blackard and Greg Mundy in San Antonio and people like that, we all have an immense debt of gratitude to owe them, because without their pioneering work, we wouldn't be able to do the things that we can do to make things better. So I'm going to talk today, and I'm really talking to the house staff today, about something that you're all going to see in your clinic. You might not know this. And I think a lot of people that work in this field try to make things complicated, and I'm going to try to make it simple. So I have to give you my disclosures. And I'm going to talk first about screening, and then talk about subtyping, and then talk about the tip of the iceberg, which is kind of why I'm trying to keep this simple. So where did it all start? Well, it started 70 years ago in Ann Arbor. Jerome Kahn, who was the chief of endocrine, who actually was a diabetologist. But, Kahn was during World War II, he was asked to study acclimatization. So the American troops were going to the Pacific Theater, and the men were collapsing in the first couple of days in the hot, humid climate. So he turned one of the floors at the University of Michigan Hospital into a sauna, and he had people go in, and all he could measure was sweat chloride. And he determined that it took about 3 days for you to acclimatize to a hot climate where you would start reducing your sweat chloride. And he, as an endocrinologist, hypothesized that there was a hormone that was responsible for this, which he called electrocortin at the time. And then, so again, this was in the 40s. And then in 1950, Reichstein and the Tate and Simpson discovered aldosterone, characterized its structure, and showed that it was the mineralocorticoid that was electrocortin that Kahn had hypothesized. So, and so he knew that this hormone caused sodium retention and potassium excreted. And this 34-year-old woman from Toledo, Ohio, came in with hypertension and hypokalemia, severe hypokalemia, to the point where she had a hypocalcemic tetany crisis because of a potassium of less than 2. And it was actually Steve Fyans who saw the patient and said, I think Dr. Kahn should see this patient. So the lady then lived in the hospital for a couple of months. We can't do that anymore. But eventually, Kahn was convinced that she had an electrocortin or aldosterone-producing tumor, and convinced a urologist to operate on her. And they were actually going to take out both of her adrenals. But it turned out that the team that was operating on the right side got there first, and there was a tumor there. And Kahn said, okay, you guys on the left can stop. And the patient's hypertension was cured. All right. And so, so this was kind of a landmark event. I don't know how many times you cure somebody's hypertension, but it sort of proved that the physiology that Kahn had discovered was related to a disease that now could be clinically manifest. And remember, Kahn couldn't measure aldosterone. He couldn't measure renin. He could only measure sweat chloride, and he still figured it out. Okay, he didn't have CT scans or adrenal vein sampling. But where are we now? So if you want to start a fist fight at a hypertension meeting, you can quibble about how common primary aldosterone is, how common primary aldosteronism is in patients with hypertension. Some people say 1%, some people say 10%. And I say it doesn't matter, because even if it's 1%, it's still an enormous number of people. So 30% of the US population has hypertension. So that's about 100 million people. So even if it's 1%, that's still 1 million people that have primary aldosteronism. And we haven't even scratched the surface on it. It is the #1 treatable risk factor for cardiovascular disease, stroke, and CKD. Hypertension is. And so therefore, I think it is prudent for us to look for this. So it doesn't even meet criteria for a rare disease, according to the NIH. So who should be screened for this, and how should they be screened? Well, obviously anybody with hypertension and hypokalemia, as Kahn described, but actually the majority of people with primary aldosteronism do not have hypokalemia. So the second population who really isn't being screened, really should be screened, is people with resistant hypertension. Treatment-resistant hypertension, meaning that they require 3 drugs at maximum doses, one of which is a diuretic for blood pressure control, or and are still not controlled, or they require 4 drugs to control their hypertension. So anytime you're considering a secondary cause, because it is the most common secondary cause of hypertension, and then a variety of other things that relate to people with a young age, people who have sustained stage 2 hypertension, people who have an adrenal mass or sleep apnea, and a first-degree relative. Now, in some countries like Japan, they actually screen everybody with hypertension. Now, I'm not going to go that far, but I think what I would say is that anytime you have an unusual situation, particularly if people don't respond to 2 drugs, that you should think about screening for primary aldosteronism. So the Endocrine Society has published clinical practice guidelines that were revised in 2016. They're actually under revision right now. They should be announced soon. So the way that they recommend case detection is with what's called an aldosterone-renin ratio. And I'll talk about this more, but basically measuring an aldosterone and a renin simultaneously. The reason is that the 2 should track in parallel, because aldosterone is stimulated by renin. So when renin is high, aldosterone should be high. When renin is low, aldosterone should be low. If renin is low and aldosterone is high, well, that's not normal. And then you have to figure out what's going on. Now, if people are not interested in pursuing a surgical outcome, such as the patient that Kahn described, then we would just treat medically. And I'm going to emphasize that today, that my goal of this talk today is not to teach you how to do adrenal vein sampling or all that other stuff, but is to get you to use more MR antagonist in your patients with difficult to manage hypertension. If they have hypokalemia, a fully suppressed renin, and aldosterone greater than 20, there isn't anything else on your differential diagnosis. There's really nothing else that causes that. So you don't need to do any confirmatory testing. But in other cases, we would do some sort of dynamic testing. And then if it's positive and they are interested in having surgical management, if possible, then we would do an adrenal CT scan, adrenal vein sampling, and manage them according to the results of this testing. All right, so let's go back to screening. So are we doing a good job screening people? Well, this is a sobering study from the National VA database, where it's looked at over the last almost 20 years, the proportion of people with treatment-resistant hypertension who are being screened for primary aldosteronism. So these light green bars are the total number of patients, which has increased over that time. And that dark green segment at the top, remember, all of these people should be screened for primary aldosteronism. That dark green tip is the people who are getting screened. And that's plotted on the line at the bottom as a percent. You see that line is pretty close to zero, and it never gets above 5%. So we're really doing a terrible job of screening people with primary aldosteronism. And does it matter? Well, if you look at this group, and it was over 1 million people that were originally enrolled, that boiled down to about 270,000 that should have been tested. Again, only about 4,000 were tested. But of the people who were tested, about 30% were treated with MR antagonists, whereas the people who weren't tested, it was only a little over 10%. So that's, again, my main message today is not about trying to sort out who has an adenoma or not, but it's about putting people on MR antagonists. In fact, what I always say is that if you thought to screen them for primary aldosteronism and they don't have it, they probably should be on an MR antagonist. All right, so screening is really more about whether renin is suppressed than whether aldosterone is high. Because the value of aldosterone, we have these arbitrary numbers that we've used throughout the years. And your percentage of disease will vary where you set that cutoff. And like everything else in medicine, it's not black or white. It's a continuum. And I'll show you that at the end here. But what you really are asking is whether renin is low. So low renin hypertension, you have to think about mineralocorticoids mediating that. One question that I get asked a lot is, do we need to stop medications? Because, drugs will mess with the renin-angiotensin system. So do we need to take people off medicines? If you think about it, most drugs used to treat hypertension are either diuretics or vasodilators. And in both cases, they're going to raise your renin. So if someone's on drugs and the renin is still suppressed, the screen is valid. So I don't stop drugs. I just leave them on when they come into the clinic and I test them. So again, the message is if renin is suppressed, the screen is valid. And it's actually very hard to raise renin in people with primary aldosteronism, even when you treat them with MR antagonists. So it's true that if someone's already on spironolactone or a Plerinoid, that you might need to stop their medication for at least 4 weeks. But really, if someone comes to me on treatment, I still check an aldosterone renin the first time I see them. And then I decide whether I need to stop medications and rescreen them. The cleanest drugs are alpha blockers and verapamil. And again, if you get an equivocal results, you can always chip away on the medicines and rescreen. So what's the sensitivity and specificity of an aldosterone-renin ratio? Well, if you measure aldosterone in nanograms per deciliter and renin as an activity in nanograms per mil per hour, if you use a value of about 20, you get about 80% sensitivity and 80% specificity. Now, if you use a higher value, your specificity doesn't get that much better, but your sensitivity plummets. So we usually do it about 20. And actually what I do is I actually don't do ratios. I actually look at the two values independently. So I'm giving you a couple of examples here. There's a few people with their aldosterone, the renin, and what wasn't said in the guidelines is the potassium. So the first patient has normal aldosterone, normal renin, normal potassium, ratio of 2, does not have primary aldosteronism. You treat them as primary hypertension. Now, the second patient has an aldosterone that's almost undetectable. It's 3. But the lab reports renin down to 0.1 nanogram per mil per hour. So the ratio is actually 30, but that's because you're basically dividing by 0. And this is why I don't use ratios, okay? Because, if your denominator is 0, everybody has primary aldosteronism. So this is, but this person actually might respond to an MR antagonist. I'll get to that later. The next patient is kind of a typical result that we get. The renin is 0.6, aldosterone is 18. That's kind of high, ratio is elevated, potassium is low normal. This is someone we would go on to confirmatory testing and then manage them further. The next one, the ratio is not quite as high, but you notice that they're hypokalemic. And this person almost certainly has primary aldosteronism because hypokalemia prevents aldosterone production and hyperkalemia increases aldosterone production. So this person almost certainly has primary aldo, and I would correct their potassium and then rescreen them. So this is why I always measure potassium with a screen. And then the last patient, this is typical of someone who is already taking spironolactone, who has primary aldosterone, very high aldosterone, renin not suppressed, ratio kind of elevated. This person, if my index of suspicion was high, I would reduce their medications and rescreen them. Now, a lot of labs have gone from plasma renin activity to direct renin, which is a renin mass assay. And the conversion factor is that a renin activity of 1 is a direct renin of about 9 picograms per mil. And our lab did a correlation when we were switching over, and there's a pretty good correlation with a slope of about 9. So I use 10. So I consider a low renin of 1 in nanograms per mil per hour for activity, and I consider it 10 in picograms per mil, and then you can correct your ratio accordingly. So it actually isn't that complicated. So as Nike says, there's no excuses, just do it, just screen people for primary aldo. All right, so that was actually pretty easy. And it gets hard after this, but you don't have to do this, all right? Or you don't have to do it yourself. And we have a few principles now that guide us in trying to decide in someone who has a positive screen who benefits from going on to more deeper stages of the workup. So this is where we get into subtyping. Now, there was a study group, the PASO group, that was organized as an international effort. We participated in this. And what they recognize is that data on success of adrenalectomy as treatment was highly variable because people would define success in a variety of ways. Some people would say it's a blood pressure of 140. Some people would say not taking any medicine. Some people would say it's a cure of hypokalemia. So what we did is we set up a Delphi method consensus. And we went through this and we answered the questions of what we considered complete, partial, and absent success for both clinical outcomes, hypertension, and biochemical outcomes, aldosterone. There were 31 experts at 28 centers, including 6 surgeons. So they reviewed about 700 cases that had biochemical data, including adrenal vein sampling, which is sort of the gold standard to localize aldosterone production and to determine who should go on to surgery. And what they found is that biochemical success, meaning lowering of aldosterone, was completely successful when surgery was guided by adrenal vein sampling in 94% of cases. That's like pretty good. But clinical success, meaning cure of hypertension, no drugs, normal blood pressure 130 over 80, was success in only about 1/3 of the cases. However, clinical success was partial, reduced blood pressure medicines, better blood pressure control in almost half the patient. So when you add that together, you have about 85% of people that are benefiting from adrenalectomy in some way. Now, clinical success was more likely if they were female versus male, younger versus older, and less likely if they had a high number of preoperative medications and, of course, were older or male. So at least these establish standardized criteria for PA management and predictive factors for guiding people whether they're going to benefit from going to the later stages of the workout and possibly having surgery. So to determine subtyping, we go down to, we've done screening. In many people, we've done confirmatory testing. We know they have primary aldosteronism. Now, where is the aldosterone coming from? It's coming from the right adrenal, the left adrenal, or both adrenals. So we used to do CT scanning, but CT scanning is too sensitive. 5% to 10% of adults have an adenoma on one or both adrenals. So the accuracy of CT scanning alone is only about 53%, which is essentially flipping a coin. Now, if they're young, the younger you are, the less likely you're going to have adrenal tumors, just like thyroid tumors. So if they're less than 35 or so, and they have an adenoma that's greater than a centimeter, and the contralateral adrenal gland is clearly normal, there is evidence that those people can go directly to adrenalectomy without any further evaluation. But really, all others require this invasive procedure and difficult procedure called adrenal vein sampling. And right now, we don't really have other options. So I'm going to show you one option that's in development, which is functional imaging. So these are C11 metamidate PET scans. Metamidate is a drug that binds to the aldosterone synthase enzyme, which is only expressed in cells that make aldosterone, such as aldosterone-producing adenomas. So the ideal result is, let's see, so the ideal result is this one here. You have a tumor on this side, a normal appearing adrenal. The PET scan localizes to that adenoma. And in bilateral disease, you have people with lumpy, bumpy little nodules on their adrenals. The PET scan is pretty equivalent. And so this is bilateral disease. But then you also have people with incidental adenomas. And sometimes the uptake is not so clear. And so it's not a perfect test. And it's not, of course, available in the United States. So I think this is one technology that might help for some people, but right now it's not ready for prime time. So we have situations like this. This is a man I took care of when I was in Dallas at Parkland Hospital. He had flaming primary aldosteronism. We did a CT scan, and he had a small tumor on the right side next to the liver, and he had a slightly larger tumor on the left side. So where's the aldosterone coming from? Now, I'm an endocrinologist, and I can't tell you by looking at the CT scan whether it's one, both, or the other. So what we do is adrenal vein sampling, and our interventional radiologist puts catheters up into the veins that drain the adrenal gland. And it turns out that the left is easy to find because it comes up superior from the left renal artery. So it's pretty easy to thread a catheter in there. The right one, unfortunately, comes straight off the inferior vena cava. And it's pretty hard to find. And so they have to sort of drag the catheter up and down the posterior part of the IVC, squirt a little dye in. And when they get a venogram that looks right, they go ahead and draw samples. And what we do to make sure we're in the right place is we first measure cortisol on samples, right? Because we know cortisol is coming from the adrenals. So that's what we call our selectivity index, measuring the cortisol in the adrenal vein, dividing by the inferior vena cava. And if you do the procedure without cosentropin, we want at least a 2-fold step up. If you do it with cosentropin stimulation, we want at least a 4-fold step up. So then we do the cortisol corrected aldosterone values. So we divide the aldosterone by the cortisol. So the lower the cortisol, the less clean a sample you are. The higher the cortisol, the more adrenal vein blood is in that sample, because you never get 100% adrenal vein blood. It's always a mixture. So we do this cortisol correction to correct for how much adrenal vein blood is in that specimen that we draw. So aldosterone divided by cortisol, right side versus left side. That's called the lateralization index. And if it's greater than 2 without cosentropin or greater than 4 with cosentropin, we consider it lateralized. We also like to see what's called contralateral suppression, meaning the ratio on the low side is actually lower than the mixed venous blood. So we're quite confident the aldosterone is not coming from that low side. And you typically get one of 2 patterns: a very high value on the high side, a value less than about 1.5 on the low side, and the IVC in between, that would be lateralized. People who are bilateral, it's very often 2 to 4 on both sides, and the IVC is between 1 and 2. So what did we find in this patient? Well, if you went after the big tumor, you would be wrong, because it's that little half-centimeter adenoma where the aldosterone is 26,000 in the right adrenal vein. So this man had the right adrenalectomy, and he was cured of his hypertension, okay, and his hypokemia. So now this is a patient from Michigan. This is an older gentleman. He's had hypertension for 30 years, hypokalemia, poor control on 3 drugs. He has an elevated aldosterone. He's variably hypokalemic, but we have a normal CT scan. So what do? Well, I don't think I can cure his hypertension because he's male, he's older, he's been on a bunch of drugs, but he's hypokalemic, which suggests that he has an adenoma hiding somewhere in those normal appearing CT scans. So we did offer him adrenal vein sampling, and his aldosterone cortisol ratio is sky high in the right side, lower in the left side than in the inferior vena cava. So he actually lateralized to the right. We sent him to surgery, and post-op, we had a complete biochemical success. His aldosterone was undetectable. And he had normal blood pressure and potassium on 2 drugs. So we didn't cure his hypertension, but this is a total win because now he's only on 2 drugs and he is controlled and he's not hypokalemic. So sometimes, even though I know I'm not going to cure their hypertension, we encourage people to go through the workup because we can simplify and improve their regimen and their care. Now contrast that to this person, 51-year-old, crazy high aldosterone, hypokalemia, 1.5 centimeter right adrenal mass, normal left side. We did send him to adrenal vein sampling, and as predicted, it lateralized to the right side where the adrenal mass was. We sent him to surgery, and he still has primary aldosteronism. It's better, and he's well controlled without hypokalemia on 2 drugs, including an MR antagonist, but he still has primary aldosteronism. So how can that be? And in fact, how do people get bilateral hyperaldosteronism in the absence of a tumor? Well, we know a lot more now thanks to the people in Japan that have studied this, and Bill Rainey at Michigan, who's my collaborator in cell biology. And what we know now is that if you look in a child or in a rat or in young people, you have a nice continuous zona glomerulosa around the adrenal. But Celso Gomez-Sanchez at Michigan has developed an antibody to the aldosterone synthase enzyme, which is essentially looking for aldosterone producing cells. And if you take adults in the United States, I joke that most Americans haven't made aldosterone in years because we live in a salt-loaded society. In most Western countries, there's no need to make aldosterone. And so we actually are doing a selection experiment that the only cells in the adrenal that make aldosterone that survive are ones that don't need renin. Okay, and so what you find is these what was called in this paper aldosterone producing cell clusters, and we now call aldosterone producing micronodules. So like right here, there's this cluster of cells that are making aldosterone, but there's no zona glomerulosa going all around. Okay, so a cluster here, cluster there, a couple of clusters here. So now you can imagine that if people get a lot of these clusters on both adrenals, that they're eventually going to have primary aldosteronism. When you look at these cells, they increase with age, and they have mutations in the same genes that cause aldosterone-producing adenomas, calcium channels, ATPases, phosphodiesterases. And if you do principal component analysis, they group with the zona glomerulosa, these APCCs as they were called. They group with the zona glomerulosa, and they make a ton of aldosterone synthase, which is CYP11B2, even higher than in the zona glomerulosa. So these are little autonomous aldosterone factories that, when they get large enough, can cause hypertension. So the other thing that we learned with now that we have this antibody is that we always do adrenalectomies. We don't do nodulectomies or partial adrenalectomies. And the reason is that this is a patient with primary aldosteronism. The CT scan found this tumor here, this T1 on the scan, but actually that tumor doesn't make aldosterone. It's actually this little tumor here that we didn't see that's making the aldosterone. The adrenal vein sampling told us it was coming from this adrenal, but it didn't tell us where in the adrenal it was coming from. So that's another reason why we rely only on the biochemical data. And then we get situations like this, where we take out the tumor and only part of the tumor is making aldosterone, and the other part of the tumor is got this enzyme 17-hydroxylase, which makes cortisol. So that leads us to the next phenomenon, which is if we do gene profiling in cortisol-producing adenomas versus aldosterone-producing adenomas, the difference is that the cortisol-producing adenomas do not make this aldosterone synthase CYP11B2 enzyme. But it turns out that the aldosterone-producing adenomas actually generally have 17 hydroxylase in it, which is the enzyme you don't need to make aldosterone, but you do need to make cortisol. So that's led to the recognition of what's called Cushing syndrome, which is that a lot of people, most people with primary aldosterone actually make a little bit of cortisol too. So these aren't really adenomas of the zona glomerulosa. They are unique cell types that have a mixture of enzymes, but you only need to make 1/1000th as much aldosterone to cause a clinical syndrome as you do cortisol. Cortisol is in micrograms per deciliter, aldosterone is in nanograms per deciliter. So if you look at tetrahydroaldosterone, which is the main urinary metabolite of aldosterone, the people who have high production are the people with primary aldosteronism. Sure. But if you look at total glucocorticoid metabolites, the Cushing's patients have the most. But the second highest group is people with primary aldosteronism. Okay, so so an example of that would be this woman who I took care of in Dallas again, 36-year-old Vietnamese woman who has recurrent pregnancy losses, resistant hypertension, and hypokalemia. She must have primary aldosterone. She gets screened and she has a mildly elevated aldosterone, somewhat disproportionately high to her hypokalemia. And on CT, she has a nice juicy right adrenal mass. And this is her adrenal tumor right here. Okay. And this is her left side. Now, the cardiologist that saw this patient first, being a purist, decided to do adrenal vein sampling. And when she had adrenal vein sampling, the aldosterone actually lateralized to the left side, not the right side. But if you notice, the cortisol values on the left side were quite low. Okay. And so she was referred to me. And when I took a history and examined her, she had bruising, weight gain, supraclavicular fat pads, and she had Cushing's. Okay. So she had overt Cushing's and mild hyperaldosteronism. So she had a truly co-producing tumor. And so the reason the cortisol was low on the left side is because the cortisol from the adenoma was suppressing her ACTH and suppressing the cortisol production from the normal adrenal. So the implications of cortisol co-secretion is that we sometimes now are exploring the use of other steroids, like should we normalize to cortisol if the tumor normally makes cortisol? So we can salvage up to 90% of equivocal studies by looking at other steroids from the adrenal, such as 11-deoxycortisol and 11-hydroxyandrostenedione using mass spectrometry. And then also hybrid steroids, which we used to think are only made in certain genetic forms of primary aldosteronism, are actually useful markers for aldosterone-producing adenomas. So very high levels of 18-hydroxy or 18-oxocortisol can be used in a peripheral blood sample to determine if somebody has a tumor or not. So going from the Endocrine Society guidelines, we actually decided to expand this a few years ago. And what we do now is, if you notice, that all roads lead to either MR antagonist or adrenalectomy. So if you have a positive screening test, you can then go on. But if you don't have a positive screening test, again, if you thought to screen them, I would consider MR antagonist. If they're not a surgical candidate, MR antagonist. If they are a surgical candidate, then we stop and we think and we be a doctor, okay? And we ask ourselves, how likely are they to lateralize? And then if they lateralize, how likely are they to have clinical success from an operation? So the predictors of lateralization: hypokalemia, very high urine aldosterone and presence of tumors, likelihood of clinical success, young age, short degree of hypertension and fewer meds, female sex. If I think it's pretty low, I might just treat them medically. If I think it's moderately high, I will send them on to CT scanning and adrenal vein sampling. And we're going to stick a dexamethasone suppression test in there to screen for Cushing's. But then, you know, we can always go back. If you treat with MR antagonists and things change, people worsen, they require more drugs, you can always go back and complete the workout there. If they have Cushing's, we're going to take the adrenal, the large adrenal out. If they have a large tumor, we might evaluate for cancer, but otherwise we go to adrenal vein sampling, and if they're lateralized, we do adrenalectomy. All right, so that was complicated enough. Now, what okay, so there's a subclinical hyper and hypothyroidism. There's asymptomatic hyperparathyroidism. There's got to be a subclinical primary aldo, right? You don't wake up one day with primary aldo. You develop these micronodules, and then at some point, somebody finds you and they say that, okay, you've got a problem here, but how does it develop and how do we identify it? So as I said, most Americans haven't made aldosterone in years. In the Dallas Heart Study, we measured aldosterone in 4,000 people in Dallas County, and the most common value we got was 0. Okay, so really, we're not really supposed to be making aldosterone if we're living in a salt-loaded society. So let's take people with low-renin, and let's look what happens as we plot their aldosterone levels out. And Anand Vaidya and Jennifer Brown did this in Boston. So the people with a suppressed renin, less than 0.5, if you go from first quartile to second quartile to third and fourth quartile, their rate of hypertension goes up with their aldosterone. If your renin is not suppressed, then it doesn't matter what your aldosterone is. So again, low renin, more likely the higher your aldosterone. And if you do 24-hour urine aldosterone levels in these people, you take people with untreated normal tension. These people running around the street, no medical problem, not taking any drugs. About 10% of them have primary aldosterones. Okay, meet criteria on a salt-loaded urine. If you take stage 1 or stage 2 hypertension, it goes up to 15-20%. If you take untreated resistant hypertension, about 50%. Okay, so there is a graded prevalence of hypertension. If you have a suppressed renin, the higher your aldosterone. And conversely, if you take people with worsening hypertension and a suppressed renin, the prevalence of hypertension of primary aldosterone goes up, the worse your hypertension. You can do the same thing with saline infusion. You can do dynamic studies, and you get the same picture. You get a continuum in people with normal blood pressure, stage 1, 2 hypertension, or resistant hypertension. As you go to the right with more severe hypertension, the prevalence of primary aldosteronism goes up. And I often am asked, what cutoff do I use? And I say, we don't know, because actually now the old studies were done with immunoassay aldosterone. And now we're done using mass spectrometry. And mass spectrometry reads about 30% lower. So whatever criteria you learned in medical school, they're probably a little off. So I think this is, again, where clinical judgment, that box in the middle of trying to decide, do we treat with MR antagonists or do we go to the other stages of the evaluation are most important. So what about treating with MR antagonists? How good is that? I mean, a lot of people don't use much spironolactone, but if you want to know what the best drug to treat hypertension is, it's spironolactone. So these are people's data from, on the left is from David Calhoun's group at UAB. This is people with treatment-resistant hypertension who are getting on average 25 milligrams of spironolactone a day. And their blood pressure falls by 20 to 25 millimeters. We don't have any other drugs in the formulary that do that. And then the Ascot study on the right, they found the same thing. But this was not a placebo-controlled double-blinded experiment. So then that was done. This is the Pathway 2 study by Williams and colleagues from the UK, where they randomized people to placebo, spironolactone, doxazosin, or bisoprolol, and the winner, hands down, was spironolactone. And the lesson from that study is that the lower your renin, the better your blood pressure response. So it's only when you have, and these are direct renin measurements. So these are quite elevated renin values that you don't respond to spironolactone. The lower your renin, the better your blood pressure response. So another way of showing the algorithm would be to say, people with hypertension, any of those sort of known risk factors or concerns, you get renin and aldosterone. And if the renin is high, then you think about renovascular disease. But if the renin is normal or low, you either send them to an endocrinologist or you treat them with MR antagonists. And I think this is my main message today. And then finally, because a lot of us don't use it, I think a lot of people don't know how to use MR antagonists effectively. Because it's such a potent drug and because it can cause a bump in creatinine and renal and hyperkalemia, I always start people on 12.5 milligrams a day. I've seen people come into the ER, they make a diagnosis, and then they send them home on 100 milligrams a day, and then they come in renal insufficiency with hyperkalemia 2 weeks later. So 12.5 milligrams a day chemistry's in 2 weeks, maybe 1 week if they have CKD, and I don't up titrate for 4 to 6 weeks. Spironolactone acts very slowly. It only deals with the last 2% of filtered sodium. So your blood pressure doesn't fall with your first dose. And there's also effect on the sympathetic nervous system. So there's MR in the brain, and aldosterone causes an increase in sympathetic nerve activity. That takes even longer for it to have an effect. So then I just keep doubling the dose until I get to up to about 400 milligrams a day. Usually I don't have to go above 50. It's only people with like ectopic ACTH syndrome that we have to have on such high doses. So the goal is normal blood pressure, normal potassium, and I like to see a non-suppressed renin. Now, as I titrate the dose up, I could stop other medicines, and actually I can add thiazide. Now, these people that are hypokalemic, they haven't been able to use loop diuretics or thiazides because of that. But once I have them on spironolactone and I get the potassium control, now I can add a small dose of a thiazide or a loop diuretic if they have renal insufficiency. Now, I do expect their creatinine to go up, but it should stabilize. And it's sort of like putting a patient with diabetic nephropathy on an ACE inhibitor or an ARB. You're going to get a bump in their creatinine, a little rise in their potassium, but then it's going to be renoprotective in the long run. If they have side effects from the spironolactone, I switch to a eplerenone, and I use whatever dose I was using, just divided twice a day. So 50 of spironolactone, I go to 50 twice a day of eplerenone, sometimes more. Miloride is another alternative. It's not ideal because it doesn't block the MR in peripheral tissues, but it actually does a pretty good job, very good job at controlling potassium and a reasonably good job at controlling blood pressure as well. So to summarize, screening is actually pretty easy. You don't have to stop drugs. You're really looking for a suppressed renin. It's just a simple blood test, but it's underutilized. You don't wake up one day with primary aldo. This happens over time, and there's a whole group of people out there that have aldosterone that's not high enough to meet criteria, but they have low-renin and aldosterone-mediated. The pathophysiology that we now understand with the aldosterone-producing micronodules explains the high prevalence of this disease. That was actually a quandary. People didn't really understand it. If how can you have primary aldo without a tumor? Well, you do have tumors. They're just tiny little tumors. And the co-secretion of cortisol is common. Occasionally trips us up in the evaluation, and it might be used to our advantage in the future in avoiding adrenal vein sampling in some people. So you can always stop and treat medically. And if you're going to treat medically, anybody with resistant hypertension, MR antagonist should be at the top of your list. So Einstein said that everything should be made as simple as possible, but not simpler. I tried to do that today. I think a lot of the aficionados in primary aldo like to make it complicated, and it is complicated, but I think in clinical practice, it can be actually quite simple. And then my last message is the adrenals are life, the rest is just details. That I'll close for questions.
Thank you. We'll take some questions here from the audience. Yeah, in the back.
Yeah, thanks for the presentation. What's your experience with the non-steroidal MAs?
Yeah. So finerenone, for example, it's the only one that's on the market. It's very expensive. I know only a few people that have used it. I think it's supposed to have less hyperkalemia, but I don't think it's as effective in blood pressure control. So it's really marketed as a renoprotective drug in type 2 diabetes where you don't want to lower the blood pressure too much and cause hyperkalemia. I think that's just because it's a weak MR antagonist. So there's not been a head-to-head trial. But again, I think the one situation where I think I would use it in someone who already has pretty bad renal damage and I'm worried about causing hyperkalemia, I might try it in that group. The aldosterone synthase inhibitors are being trialed now. And that's a whole nother thing, baxdrostat and lorundrostat. And I think that's interesting for two reasons. It's possible that those will actually cause less hyperkalemia than the MR antagonists. But I don't think, and they still have some episodes of that in clinical practice. But, we use a lot of spironolactone in our transgenders and for treating women with hirsutism. If they have good renal function, they never get hyperkalemia. And we use doses up to 200 milligrams a day. So I think it's really this issue of people with existing renal insufficiency where that becomes an issue. So you had a question.
Yeah, I always feel huge dissonance around this topic because as you showed, there's this huge public health problem with hypertension and then aldosterone-associated hypertension that we underdiagnose and undertreat and all these things. And so if you had the magic wand to fix this as a public health problem, would you think about screening people at certain ages with renin levels or I'm trying to think through what you might do to actually address this from the bigger.
Yeah,
public
I mean,
health.
some people have said that everybody should get a renin, right? You don't have to get the aldosterone, right? So, but I think the aldosterone then helps you to say, well, should I evaluate them further? So, so I would say if people aren't controlled, I usually, what are blood pressure control rates now in the United States? They're pathetic. They're like what? 40% of people have their blood pressure controlled. There's some ridiculously low number. And you usually have to start people on 2 drugs. So if people are on 2 drugs and they're not controlled, that would prompt me to screen them. And if the renin is low, then I would, and their aldosterone wasn't that high, I would just add MR antagonists. That's how I would do it. But if they're hypokalemic, if they're relatively young, if their aldosterone is pretty high, I would send them to one of us and go further in.
So I guess my dissonance is that we've said that for many years and we've not really moved the.
We haven't.
As far.
So Adina Turku started a BPA in Epic, one of these alerts that, hey, you should get an aldosterone renin, and it helped, but it didn't totally help. And in Australia, they're doing a similar event, and I think that the main reason that we're getting is that people are thinking that they have to stop medicines to do this. So I think that's the message that we haven't quite gotten out is you don't need to stop. Because again, the aldosterone aficionados in Japan and Italy, they write these review articles and they have like lists and lists. And the point is that drugs cause false negative, not false positive. Okay. And if the drug is causing a false negative, they probably don't have bad primary aldo and they probably don't have a tumor. So to me, you have nothing to lose. So that's what we need to add to the BPA is that no, don't stop drugs, just get it today. That's, I think, the message that needs to go out. Yeah. Yes.
What do we know about the relationship between primary hyperaldo and disordered sleep or the obstructive sleep apnea?
Right. Yeah. Yeah.
That showed up as a case finding thing with the last ones, but I don't know if I've heard why.
So that came from David Calhoun's studies. So they had, because so all the house officers should know the 5 causes of treatment-resistant hypertension. You think, renal insufficiency, alcohol, sleep apnea, medication non-adherence, and mineralocorticoids. All right. And so in their clinic where they're dealing with these treatment-resistant hypertension patients, they're doing a lot of sleep studies and they're also screening for primary aldo. And they actually find that a lot of people have both. So that's where it comes from. But they both can cause, so I wouldn't not, even if you put somebody on MR antagonist, if they have sleep apnea, they need their sleep apnea treatment. So I don't think we have evidence in the other direction about primary aldo causing sleep apnea. And I don't think we would say that sleep apnea causes primary aldo, even though, it might because of chronic hypoxia and stuff. But it's sort of the common co-occurrence, the co-occurrence of 2 common things. Yeah. So, the other caveat would be, so let's say somebody does have treatment-resistant hypertension, they have sleep apnea, they go and they get on CPAP, and they comply with the CPAP, and their blood pressure improves. They probably don't need screening for primary aldo. But if blood pressure doesn't improve, they should be screened for primary. Yeah, it's like erectile dysfunction and subnormal testosterone. It's 2 things that are very common, but really aren't, that are quasi-related, but really aren't cause and effect. Yeah. Yes, no, sorry, he had a,
with all the kind of what you were describing with the CT scan and the renal sampling and not being super helpful sometimes, how strongly do you suggest going down that route, or do you kind of just start with medication instead?
Well, CT scanning is really to look for a large tumor, not to look for small tumors. So I just want to make sure there's not, and then if I see a 2.5 or larger tumor, then I'm very concerned about cortisol excess. And so then I pay more attention. that affects my pretest probability for an abnormal dexamethasone expression. So that's one thing. But some people have argued that you should go right to adrenal vein sampling and not do that. Now, the adrenal vein sampling is actually quite good, but we do find about 10% of the time we have these, discordant tests or these tests that don't quite fit in, or that if we draw 3 samples, 2 of them are lateralized and 1 is not. And I think it's more that, again, if we think that if we sent them to adrenal vein sampling, we think that they benefit from surgery. So we would then have a situation where we would, go over it with the surgeon and say, I think this person is going to benefit, even if we don't cure them of their primary. I like that patient I showed you. I'm going to send them anyway. So whereas if it's a slam dunk, then there's no question about that. So our surgeons like to have it done because they want to be confident about it. But I still think, adrenal vein sampling criteria were not determined from data. They were sort of arbitrarily come up with, and then people said, well, I think 4. I think 4 is the ratio we should use. And it seemed to work, but what about 3.5? What about 3? What about, and people don't really do that. I know that the lowest gradient that I've sent somebody to surgery in was 2.5. And that was because there was contralateral suppression on the other side. And that person was cured of both their primary aldo and their and their hypertension. So so I think this is why I think adrenal vein sampling, I didn't go into detail because it's more medicine grand rounds, but that's another thing. You start fits fights, but there's with or without cosentropin, and there's like, how do you do super selective sampling, or do you selective sampling? We could spend a whole day quibbling about that. But I think the point is you do it the same way every time. You have a team that does the evaluation the same way every time. And you get good at doing it that way. So whatever you do, keep doing it. Don't do it a different way someday because then you're not comfortable with that. So and collect data and review your data periodically so that you know if what you're doing is working. Yeah, but it is still an ongoing debate. Yeah. And then you have no question. Yes.
Do you ever do self-suppression testing anymore?
Occasionally, I got to say, since the people that I see usually have an aldosterone greater than 20, so I haven't done confirmatory testing in a long time. But if I do the oral salt loading, can of Campbell's soup, and then 24-hour urine on the 3rd day, because that gives me a good integrated value. And that tells me how likely, when I say high aldosterone, it's really the urine aldosterone that's more informative in that regard. So if they're urine aldosterone, we usually say 12 or 14 is sort of the cutoff. If it's 8 or 9, normal is less than 4, right? So you're in that gray zone. You probably don't have a tumor, but you'll respond to MR antagonist. If you're 30, you probably have a tumor. And then I want you to go on to the later stages of the workout. So that's when I use it, when I need some more data to decide whether I'm going to do the CT and ABS versus just treating medically. If I already know I'm just going to treat medically, then I don't even do it. Yeah. But I prefer that to the saline infusion, because then you only get one aldosterone sample, and because of the pulsatility of aldosterone, you can miss it. Yeah.
Well, thank you so much for your lecture.
Okay, I guess we dismiss everybody. You are class dismissed. No, that's right. No, this is great. Insight. Okay, all right.
Thank you. I really enjoyed the clinical
Okay.
paper.
Did you have a meeting?
Yeah, all right.